Thromboembolic disease in pregnancy and the Puerperium, acute management. Green Tab Guideline number 37b, April 2015. Introduction and background epidemiology. Venous thromboembolism or VTE remains one of the main direct causes of maternal death in the UK. The subjective clinical assessment of deep venous thrombosis or DVT and pulmonary embolism or PE is particularly unreliable in pregnancy, and only a minority of women with clinically suspected VTE have the diagnosis confirmed when objective testing is employed. The prevalence of ultimately diagnosed PE in pregnant women with suspected PE is 2 to 6%. The risk of antenatal VTE or venous thromboembolism is 4 to 5-fold higher in pregnant women than in non-pregnant women of the same age, although the absolute risk remains low at around 1 in 1,000 pregnancies. Venous thromboembolism can occur at any stage of pregnancy, but the puerperium is the time of highest risk, with estimates of relative risk of approximately 20-fold. The majority of women with VTE in pregnancy have clinical symptoms. The symptoms and signs of DVT include leg pain and swelling, usually unilateral, and lower abdominal pain, reflecting extension of thrombus into the pelvic vessels and or development of a collateral circulation, and the symptoms of PE include dyspnea, chest pain, hemoptysis, and collapse. It is noteworthy that a low-grade pyrexia and leukocytosis can occur with venous thromboembolism. Diagnosis of acute venous thromboembolism. How is acute VTE diagnosed in pregnancy? Any women with symptoms and or signs suggestive of VTE should have objective testing performed expeditiously and treatment with low molecular weight heparin or LMWH given until the diagnosis is excluded by objective testing unless treatment is strongly contraindicated. Individual hospitals should have an agreed protocol for the objective diagnosis of suspected VTE during pregnancy. This may recommend the involvement of obstetricians, radiologists, physicians, and hematologists. If DVT or deep vein thrombosis remains untreated, 15 to 24% of these patients will develop pulmonary embolism. PE or pulmonary embolism during pregnancy may be fatal in almost 15% of patients, and in 66% of this, death will occur within 30 minutes of the embolic event. What investigations are needed for the diagnosis of an acute deep vein thrombosis or DVT? Compression duplex ultrasound should be undertaken where there is clinical suspicion of DVT. If ultrasound is negative and there is a low level of clinical suspicion, anticoagulant treatment can be discontinued. If ultrasound is negative and a high level of clinical suspicion exists, anticoagulant treatment should be discontinued, but the ultrasound should be repeated on days 3 and 7. Compression duplex ultrasound is a primary diagnostic test for DVT or deep vein thrombosis. If ultrasound confirms the diagnosis of DVT, anticoagulant treatment should be continued. If ultrasound is negative and a high level of clinical suspicion exists, anticoagulant treatment should be discontinued, but the ultrasound repeated on days 3 and 7. If repeat testing is negative, no further treatment is required. If repeat testing confirms the presence of DVT, anticoagulant treatment should be recommenced and continued. When iliac vein thrombosis is suspected, back and buttock pain and swelling of the entire limb, Doppler ultrasound of the iliac vein, magnetic resonance venography, or conventional contrast venography may be considered, although in practice, because of the extensive nature of these thrombi, ultrasound venography will often suffice. What investigations are needed for the diagnosis of an acute PE or pulmonary embolism? Women presenting with symptoms and signs of an acute pulmonary embolism or PE should have an electrocardiogram or ECG and a chest X-ray performed. In women with suspected pulmonary embolism who also have symptoms and signs of DVT, compression duplex ultrasound should be performed. If compression ultrasonography confirms the presence of DVT, no further investigations is necessary and treatment for VTE should continue. In women with suspected PE without symptoms and signs of DVT, a ventilation perfusion, VQ, lung scan, or a computerized tomography pulmonary angiogram or CTPA should be performed. When the chest X-ray is abnormal and there is a clinical suspicion of PE, computerized tomography pulmonary angiogram or CTPA should be performed in preference to a VQ scan. Alternative or repeat testing should be carried out where VQ scan or CTPA is normal but the clinical suspicion of PE remains. Anticoagulant treatment should be continued until pulmonary embolism is definitively excluded. Women with suspected PE should be advised that, compared with CTPA, VQ scanning may carry a slightly increased risk of childhood cancer but is associated with a lower risk of maternal breast cancer. In both situations, the absolute risk is very small. Where feasible, women should be involved in the decision to undergo computerized tomography pulmonary angiogram or CTPA or ventilation perfusion or VQ scanning. Ideally, informed consent should be obtained before these tests are undertaken. In pregnancy and puerperium, one study found that ECG was abnormal in 41% of women with acute pulmonary embolism. The most common abnormalities were T-wave inversion, 21%, S1, Q3, T3 pattern, 15%, and right bundle branch block, 18% during pregnancy, and 4.2% in the puerperium. Given the increasing incidence of ischemic heart disease in pregnancy, the ECG may also be helpful in identifying alternative diagnosis. Chest X-ray may identify other pulmonary disease such as pneumonia, pneumothorax, or lobar collapse. While the chest X-ray is normal in over half of the pregnant patients with objectively proven pulmonary embolism, abnormal features caused by pulmonary embolism include atelectasis, effusion, focal opacities, regional oligemia, or pulmonary edema. The radiation dose to the fetus from a chest X-ray performed at any stage of pregnancy is negligible, less than 0.01 msv. A chest X-ray should be performed before deciding upon further diagnostic tests. A normal chest X-ray prior to ventilation perfusion scanning improves the likelihood of a definitive ventilation perfusion result. If the chest X-ray is abnormal with a clinical suspicion of pulmonary embolism, CTPA should be performed. Pregnant women with suspected pulmonary embolism who have symptoms and signs of deep vein thrombosis should have bilateral compression duplex ultrasound leg studies performed. A diagnosis of DVT may indirectly confirm a diagnosis of pulmonary embolism, and since anticoagulant therapy is the same for both conditions, further investigation may not be necessary. This would limit the radiation doses given to the mother and her fetus. Given the higher incidence of isolated iliac vein deep vein thrombosis in pregnancy, it would be anticipated that there would be an increased likelihood of false negative results with this strategy. Therefore, while a positive result is of value, a negative investigation does not help to exclude a pulmonary embolism. The choice of technique for definitive diagnosis, VQ scan or CTPA, will depend on local availability, and individual hospitals should have an agreed protocol for the objective diagnosis of suspected pulmonary embolism during pregnancy. With regard to ventilation perfusion lung scanning, during pregnancy, the ventilation component can often be omitted, thereby minimizing the radiation dose for the fetus. Studies have compared ventilation perfusion or low-dose perfusion Q scans with CTP for the detection of pulmonary embolism in pregnancy and have found comparable negative predictive values, 99% and 100% for CTPA and Q scans respectively. CTPA or computerized tomography pulmonary angiogram has potential advantages over ventilation perfusion imaging, including CTPA is more readily available, delivers a low radiation dose to the fetus, and can identify other pathology including pneumonia 5 to 7%, pulmonary edema 2 to 6%, and rarely aortic dissection. Despite these potential advantages of CTPA, many authorities continue to recommend VQ scanning as first-line investigation in pregnancy because of its high negative predictive value in this situation and its substantially lower radiation dose to pregnant breast tissue. Clinicians arranging imaging scans for suspected pulmonary embolism in pregnancy should be aware of the potential risk surrounding fetal and maternal radiation exposure. With both techniques, the doses employed are well below accepted threshold for teratogenicity, fetal death, and fetal growth restriction, and the main concern for the fetus is a very small increased risk of childhood cancer. The fetal radiation exposure associated with CTPA and VQ is approximately 0.1 milligray and 0.5 milligray respectively. While CTPA or computerized tomography pulmonary angiogram is associated with a low risk of radiation for the fetus, this must be offset by the relatively high radiation dose, up to 20 milligray, to the mother's breast tissue, which is associated with an increased risk of breast cancer. The dose estimate for CTPA is 20 to 100 times greater than for VQ scanning. The radiation dose depends on breast size, the technique used, and the age of the woman, the risk of cancer being greater in younger women. The delivery of 10 milligray of radiation to a woman's breast has been estimated to increase her lifetime risk of developing breast cancer by 13.6% above her background risk. Breast tissue is especially sensitive to radiation exposure during pregnancy because of hormonally induced increased glandular activity. The breast doses associated with CTPA can be reduced by 20 to 40% by the use of bismuth shields placed over the breasts. It would be prudent to recommend that lung perfusion scans should be considered the investigation of first choice for young women, especially if there is a family history of breast cancer or the patient has had a previous chest CT scan. There is a theoretical risk of hypothyroidism for neonates who have been exposed in utero to iodinated contrast medium, such as that employed during CTPA, although this has not been borne out in a study of over 300 neonates. Newer imaging techniques for the diagnosis of pulmonary embolism have been developed but have not been fully evaluated in pregnancy. These include magnetic resonance pulmonary angiogram, digital subtraction angiography, and ventilation and perfusion single photon emission computed tomography. Should D-dimer testing be performed prior to objective diagnosis? D-dimer testing should not be performed in the investigation of acute VTE or venous thromboembolism in pregnancy. In pregnancy, there is a progressive rise in D-dimer levels with advancing gestation, and levels become abnormal at term and in the postnatal period in most healthy pregnant women. D-dimer levels are increased further in multiple pregnancies following cesarean section and in major postpartum hemorrhage, and if there is concomitant preeclampsia. Thus, a positive D-dimer test in pregnancy is not necessarily consistent with venous thromboembolism. The role of D-dimer testing in the investigation of acute VTE in pregnancy remains controversial. A negative D-dimer is inadequate to exclude pulmonary embolism in pregnancy. What is the role of pretest probability assessment? Clinicians should be aware that, at present, there is no evidence to support the use of pretest probability assessment in the management of acute venous thromboembolism in pregnancy. Baseline blood investigations. What baseline blood investigation should be performed before initiating anticoagulant therapy? Before anticoagulant therapy is commenced, blood should be taken for a full blood count, coagulation screen, urea and electrolytes, and liver function tests. Performing a thrombophilia screen prior to therapy is not recommended. The use of anticoagulant therapy can be influenced by renal and hepatic function and can influence the platelet count, and blood should be taken to confirm that these are normal before commencing treatment. Almost half of all women who have an episode of venous thromboembolism in pregnancy will have an underlying heritable or acquired thrombophilia. In the non-pregnant individual, the presence of thrombophilia does not alter the acute management of VTE with regards to the choice of anticoagulant agent, intensity of treatment, or duration of therapy, and therefore, testing for thrombophilia is not recommended. Furthermore, the physiological changes of pregnancy and pathophysiology of acute thrombus can influence the results of a thrombophilia screen. Levels of antithrombin and protein C may fall, particularly if the thrombus is extensive. In addition, protein S levels fall in normal pregnancy, and unacquired activated protein C resistance is found in around 40% of pregnancies. It is recommended, therefore, that a thrombophilia screen should not be performed in pregnant women on presentation with suspected venous thromboembolism. Initial anticoagulant treatment of venous thromboembolism in pregnancy. What is the initial treatment of VTE in pregnancy? In clinically suspected deep vein thrombosis or pulmonary embolism, treatment with low molecular weight heparin or LMWH should be commenced immediately until the diagnosis is excluded by objective testing unless treatment is strongly contraindicated. Low molecular weight heparins or LMWH are more effective, are associated with a lower risk of hemorrhagic complications, and are associated with lower mortality than unfractionated heparin in the initial treatment of DVT in non-pregnant patients. LMWH treatment was associated with lower rates of VTE recurrence or extension. There is evidence that low molecular weight heparins do not cross the placenta. Low molecular weight heparin is a safe and effective alternative to unfractionated heparin as an anticoagulant during pregnancy. One of the advantages of low molecular weight heparin over unfractionated heparin is the potential reduced risk of bleeding. This of particular relevance in obstetric practice, where obstetric hemorrhage remains the most common cause of severe obstetric morbidity. Low molecular weight heparins are not associated with an increased risk of severe postpartum hemorrhage, defined as a blood loss of 1,000 milliliters or more in vaginal delivery. It is known that the risk of heparin-induced thrombocytopenia, or HIT, is substantially lower with low molecular weight heparin use compared with unfractionated heparin. Data on LMWH also substantiate a lower risk of low molecular weight heparin compared with unfractionated heparin for heparin-induced osteoporosis. In clinically suspected venous thromboembolism, low molecular weight heparin should be postponed until objective testing has confirmed the diagnosis in women at risk of bleeding after careful consideration of the balance of risk of hemorrhage and clotting. Women who are known to be allergic to low molecular weight heparin should be offered an alternative anticoagulant preparation. What is the therapeutic dose of low molecular weight heparin in pregnancy? LMWH should be given in doses titrated against the woman's booking or early pregnancy weight. There is insufficient evidence to recommend whether the dose of LMWH should be given once daily or in two divided doses. There should be clear local guidelines for the dosage of low molecular weight heparin to be used. During pregnancy, changes in volume of distribution and renal glomerular filtration rate result in alterations in the pharmacokinetics of low molecular weight heparins. Several studies have provided reassuring data on safety and efficacy of once-a-daily dosing. Table number 1A. Initial dose of enoxaparin is determined as follows. Booking or early pregnancy weight, less than 50 kilograms. Initial dose of enoxaparin, 40 milligrams twice daily or 60 milligrams once daily. 50 to 69 kilograms, 60 milligrams twice daily or 90 milligrams once daily. 70 to 89 kilograms, 80 milligrams twice daily or 120 milligrams once daily. 90 to 109 kilograms, 100 milligrams twice daily or 150 milligrams once daily. 110 to 125 kilograms, 120 milligrams twice daily or 180 milligrams once daily. Greater than 125 kilograms should be discussed with hematologist. Table number 1B. Initial dose of dalteparin is determined as follows. Booking or early pregnancy weight, less than 50 kilograms. Initial dose of dalteparin, 5,000 international units or IU twice daily or 10,000 IU once daily. 50 to 69 kilograms, 6,000 IU twice daily or 12,000 IU once daily. 70 to 89 kilograms, 8,000 IU twice daily or 16,000 IU once daily. 90 to 109 kilograms, 10,000 IU twice daily or 20,000 IU once daily. 110 to 125 kilograms, 12,000 IU twice daily or 24,000 IU daily. Greater than 125 kilograms should be discussed with hematologist. Table number 1C. Initial dose of tinzaparin is determined as follows. Initial dose of tinzaparin based on booking or early pregnancy weight, 175 units per kilograms once daily. Lower doses of low molecular weight heparin should be employed if the creatinine clearance is less than 30 millimeters per minute, enoxaparin and dalteparin are less than 20 milliliters per minute with tinzaparin. Should blood tests be performed to monitor heparin therapy in pregnancy? Routine measurement of peak anti-10A activity for patients on low molecular weight heparin for treatment of acute venous thromboembolism in pregnancy or postpartum is not recommended, except in women at extremes of body weight, less than 50 kilograms and 90 kilograms or more, or with other complicating factors, for example, with renal impairment or recurrent venous thromboembolism. Routine platelet count monitoring should not be carried out. Obstetric patients who are post-operative and receiving unfractionated heparin should have platelet count monitoring performed every 2 to 3 days from days 4 to 14 or until heparin is stopped. The platelet count should be checked after 24 hours of initiating treatment if the patient has previously received heparin, unfractionated or low molecular weight heparin in the last 100 days. The frequency of heparin-induced thrombocytopenia or HIT is greater in surgical than medical patients and is more likely with unfractionated heparin. How should massive life-threatening pulmonary embolism in pregnancy and the puerperium be managed? Collapse-shocked women who are pregnant or in the puerperium should be assessed by a team of experienced clinicians, including the on-call consultant obstetrician. Women should be managed on an individual basis regarding intravenous unfractionated heparin, thrombolytic therapy, or thoracotomy and surgical embolectomy. Management should involve a multidisciplinary team including senior physicians, obstetricians, and radiologists. Intravenous unfractionated heparin is the preferred initial treatment in massive pulmonary embolism with cardiovascular compromise. Maternity units should develop guidelines for the administration of intravenous unfractionated heparin. The on-call medical team should be contacted immediately. An urgent portable echocardiogram or CTPA within 1 hour of presentation should be arranged. If massive pulmonary embolism is confirmed or in extreme circumstances prior to confirmation, immediate thrombolysis should be considered. Massive pulmonary embolism may present with shock, refractory hypoxemia, and/or right ventricular dysfunction on echocardiogram and is a medical emergency. Collapse-shocked women who are pregnant or in the puerperium should be assessed by a multidisciplinary resuscitation team of experienced clinicians, including the on-call consultant obstetrician, who should decide on an individual basis whether a woman receives intravenous unfractionated heparin, thrombolytic therapy, or thoracotomy and surgical embolectomy. Maternal resuscitation should commence following the principles of ABC, and if cardiac arrest occurs, cardiopulmonary resuscitation should be performed with the woman in a left lateral tilt. A perimortem cesarean section should be performed by 5 minutes if resuscitation is unsuccessful and the pregnancy is more than 20 weeks. Intravenous unfractionated heparin is the preferred initial treatment in massive pulmonary embolism because of its rapid effect, extensive experience on its use in this situation, and since it can be adjusted more readily if thrombolytic therapy is administered. One regimen for the administration of intravenous unfractionated heparin is loading dose of 80 units per kilogram, followed by a continuous intravenous infusion of 18 units per kilogram per hour. If a patient has received a thrombolysis, The loading dose of heparin should be omitted and an infusion started at 18 units per kilogram per hour. It is mandatory to measure activated partial thromboplastin time or APTT level 4 to 6 hours after the loading dose, 6 hours after any dose change, and then at least daily when in the therapeutic range. The therapeutic target APTT ratio is usually 1.5 to 2.5 times the average laboratory control value. It is recognized that activated partial thromboplastin time monitoring of unfractionated heparin is technically problematic, particularly in late pregnancy when an apparent heparin resistance occurs due to increased fibrinogen and factor VIII, which influence the activated partial thromboplastin time. This can lead to unnecessarily high doses of heparin being used with subsequent hemorrhagic problems. Where such problems are considered to exist, hematologists should be involved in the patient's management. It may be useful to determine the anti-10A level as a measure of heparin dose. With unfractionated heparin, a lower level of anti-10A is considered therapeutic, target range 0.35 to 0.7 units per ml or 0.5 to 1.0 units per ml for patients with life-threatening pulmonary embolism. In massive life-threatening pulmonary embolism with hemodynamic compromise or with limb or life-threatening ischemic complications from extensive iliofemoral vein thrombosis, thrombolytic therapy should be considered as anticoagulant therapy alone will not reduce the obstruction in the circulation. After thrombolytic therapy has been given, an infusion of unfractionated heparin can be given, but the loading dose should be omitted. Thrombolytic therapy is more effective than heparin therapy in reducing clot burden and improving hemodynamics. Current recommendations suggest that thrombolytic therapy should be reserved for patients with severe pulmonary thromboembolism with hemodynamic compromise. A major concern regarding the use of thrombolytic therapy in pregnancy is fetal and maternal bleeding. If the patient is not suitable for thrombolysis or is moribund, a discussion with the cardiothoracic surgeons with a view to urgent thoracotomy should be had. Additional therapies. Should graduated elastic compression stockings be employed in the acute management of venous thromboembolism in pregnancy? In the initial management of DVT, the leg should be elevated and a graduated elastic compression stocking applied to reduce edema. Mobilization with graduated elastic compression stockings should be encouraged. Randomized controlled trials have shown that early ambulation with leg compression does not increase the risk of pulmonary embolism, does not increase thrombus propagation, and that pain and swelling improved faster compared to those patients who had their mobility restricted. This approach may also prevent the development of post-thrombotic syndrome. National guidance in the UK recommends that patients with proximal DVT or deep vein thrombosis should be offered below knee compression stockings with an ankle pressure greater than 23 millimeters of mercury, and that hosiery does not need to be worn on the unaffected leg. Accurate fitting and careful instruction in the correct application of the hosiery is essential to avoid discomfort and assist rather than prevent venous return. What is the role of inferior vena cava filters in the management of venous thromboembolism in pregnancy? Consideration should be given to the use of a temporary inferior vena cava filter in the peripartum period for patients with iliac vein venous thromboembolism to reduce the risk of pulmonary embolism, or in patients with proven deep vein thrombosis and who have recurrent pulmonary embolism despite adequate anticoagulation. Placement of temporary inferior vena cava or IVC filter in obstetric practice is indicated when recurrent thromboembolism occurs despite adequate anticoagulation or when anticoagulation is contraindicated, such as the peripartum period. The long-term safety of IVC filters is uncertain, and the main complications associated with vena cava filters are migration, an increased risk of lower limb DVT, and caval thrombosis, and rarely infection. Maintenance treatment of venous thromboembolism. What is the maintenance treatment of deep vein thrombosis or pulmonary embolism? Treatment with therapeutic doses of subcutaneous low molecular weight heparin should be employed during the remainder of the pregnancy and for at least 6 weeks postnatally, and until at least 3 months of treatment has been given in total. Women should be taught to self-inject low molecular weight heparin and arrangements made to allow safe disposal of needles and syringes. Outpatient follow-up should include clinical assessment and advice with monitoring of blood platelets and peak anti-10A levels if appropriate. Pregnant women who develop heparin-induced thrombocytopenia or have heparin allergy and require continuing anticoagulant therapy should be managed with an alternative anticoagulant under specialist advice. Women with antenatal VTE can be managed with subcutaneous therapeutic doses of low molecular weight heparin for the remainder of the pregnancy. If low molecular weight heparin therapy requires monitoring, for example, extremes of body weight or renal impairment, the aim is to achieve a peak anti-10A activity 3 hours post-injection of 0.5 to 1.2 units per ml. The rationale for recommending therapeutic doses of low molecular weight heparin rather than reduced prophylactic doses throughout the remainder of the pregnancy is based on the continuing risk of recurrent venous thromboembolism during this time arising from pregnancy-related changes in the coagulation system, reduced venous flow velocity, a higher incidence of isolated iliac vein deep vein thrombosis in pregnancy, and in at least 50% of patients, a thrombophilia will be present. Reducing to an intermediate dose may be useful in pregnant women at increased risk of bleeding or osteoporosis. Women should be taught to self-inject and can then be managed as outpatients until delivery. Allergic skin reactions to heparin can occur and may require the heparin preparation to be changed. All lesions were caused by allergic delayed type hypersensitivity reactions. In women who are unable to tolerate heparin, usually because of allergic skin reactions, without evidence of heparin-induced thrombocytopenia, an alternative low molecular weight heparin can be prescribed, although the cross-reactivity rate to different heparin preparations is 33.3%. Where the problem persists, or in women with HIT, the use of the naparoid, a low molecular weight heparinoid, can be considered. The naparoid is an effective and safe antithrombotic in pregnancy for women who are intolerant of heparin. Can vitamin K antagonist be used during pregnancy for the maintenance treatment of venous thromboembolism? Because of their adverse effects on the fetus, vitamin K antagonists such as warfarin should not be used for antenatal venous thromboembolism treatment. Vitamin K antagonists cross the placenta readily and are associated with adverse pregnancy outcomes, including miscarriage, prematurity, low birth weight, neurodevelopmental problems, and fetal and neonatal bleeding. They are also associated with a characteristic embryopathy following fetal exposure in the first trimester. Is there a role for the new anticoagulants in the treatment of venous thromboembolism in pregnancy? Consideration should be given to the use of newer anticoagulants such as fondaparinux, argatroban, or R-hiridine in pregnant women who are unable to tolerate heparin or low molecular weight heparin or unfractionated heparin or the naparoid and who require continuing anticoagulant therapy. These preparations are administered parenterally and include fondaparinux, a selective factor Xa inhibitor, argatroban, a direct thrombin inhibitor, and R-hiridine, a direct thrombin inhibitor. The non-vitamin K antagonist oral anticoagulants are likely to cross the placenta and have potential direct fetal effects. They should therefore be avoided in the antenatal period. Anticoagulant therapy during labor and delivery. Should anticoagulant therapy be altered during labor and delivery? When venous thromboembolism occurs at term, consideration should be given to the use of intravenous unfractionated heparin, which is more easily manipulated. The women in low molecular weight heparin for maintenance therapy should be advised that once she is in established labor or thinks that she is in labor, she should not inject any further heparin. Where delivery is planned, either by elective cesarean section or induction of labor, low molecular weight heparin maintenance therapy should be discontinued 24 hours prior to planned delivery. Regional anesthetic or analgesic techniques should not be undertaken until at least 24 hours after the last dose of therapeutic low molecular weight heparin. Low molecular weight heparin should not be given for 4 hours after the use of spinal anesthesia or after the epidural catheter has been removed. and the epidural catheter should not be removed within 12 hours of the most recent injection. Where possible, anticoagulant therapy should be altered to avoid an unwanted anticoagulant effect during delivery. For elective delivery, low molecular weight heparin should be stopped 24 hours before induction of labor or cesarean section. Subcutaneous unfractionated heparin should be discontinued 12 hours before, and intravenous unfractionated heparin stopped 6 hours before induction of labor or regional anesthesia. Women who present in labor shortly after injecting low molecular weight heparin can be reassured that bleeding complications are very uncommon with low molecular weight heparin. If spontaneous labor occurs in women receiving therapeutic doses of subcutaneous unfractionated heparin, careful monitoring of the APTT is required. If it is markedly prolonged near delivery, protamine sulfate may be required to reduce the risk of bleeding. When venous thromboembolism occurs at term, the risk of recurrent thrombosis may be increased if anticoagulant therapy is discontinued to allow a planned induction of labor or cesarean section. One study suggested that the risk of recurrent VTE is higher within 2 weeks of the initial thrombosis. Consideration can be given to the use of intravenous unfractionated heparin, which is more easily manipulated and, because of its shorter half-life, minimizes the duration without anticoagulant therapy. The incidence of spinal hematoma after regional anesthesia with or without antithrombotic therapy in the obstetric population is unknown. For delivery by elective cesarean section, the treatment doses of low molecular weight heparin should be omitted for 24 hours prior to surgery. A thromboprophylactic dose of low molecular weight heparin, enoxaparin 40 mg, dalteparin 5,000 international units, tinzaparin 75 international units per kilogram should be given 4 hours post-operatively, at least 4 hours after removal of the epidural catheter if appropriate, and the treatment dose recommends 8 to 12 hours later. Are specific surgical measures required for anticoagulated patients undergoing delivery by cesarean section? In patients receiving therapeutic doses of low molecular weight heparin, wound drains, abdominal and rectus sheath should be considered at cesarean section, and the skin incision should be closed with interrupted sutures to allow drainage of any hematoma. A case control study has reported an increased incidence of wound complications in women receiving peripartum anticoagulation. What anticoagulant therapy should be employed in women at high risk of hemorrhage? Any woman who is considered to be at high risk of hemorrhage and in whom continued heparin treatment is considered essential should be managed with intravenous unfractionated heparin until the risk factors for hemorrhage have resolved. Unfractionated heparin has a shorter half-life than low molecular weight heparin, and its activity is more completely reversed with protamine sulfate. It should therefore be used in situations when anticoagulation is required but concerns exist regarding bleeding, These situations include antepartum hemorrhage, coagulopathy, progressive wound hematoma, suspected intra-abdominal bleeding, and postpartum hemorrhage. If a woman develops a hemorrhagic problem while on low molecular weight heparin, the treatment should be stopped and advice sought from a hematologist. Protamine sulfate reverses the anti-2A fraction of low molecular weight heparin but does not fully reverse the anti-10A effect. Case series have shown that it is useful in the management of bleeding associated with low molecular weight heparin in some, but not all, patients. Postnatal anticoagulation. How should anticoagulation be managed postnatally? Therapeutic anticoagulant therapy should be continued for the duration of the pregnancy and for at least 6 weeks postnatally and until at least 3 months of treatment has been given in total. Before discontinuing treatment, the continuing risk of thrombosis should be assessed. Women should be offered a choice of low molecular weight heparin or oral anticoagulant for postnatal therapy after discussion about the need for regular blood tests for monitoring of warfarin, particularly during the first 10 days of treatment. Postpartum warfarin should be avoided until at least the 5th day and for longer in women at increased risk of postpartum hemorrhage. Women should be advised that neither heparin, unfractionated or low molecular weight heparin, nor warfarin is contraindicated in breastfeeding. Both heparin and warfarin are satisfactory for use postpartum. New or novel oral anticoagulants could be considered in women who are not breastfeeding, although no reports were identified of their use in the puerperium. Before discontinuing treatment, the continuing risk of thrombosis should be assessed. If the woman chooses to continue with low molecular weight heparin postnatally, then the doses and dosage schedule that were employed antenatally should be continued. If the woman chooses to commence warfarin postpartum, this should be avoided until at least the 5th postnatal day. Daily testing of the International Normalized Ratio or INR is recommended during the transfer from low molecular weight heparin to warfarin to avoid over-anticoagulation. Warfarin administration should be delayed in women considered to be at risk of postpartum hemorrhage. The postpartum women require larger doses of warfarin and take significantly longer to reach therapeutic INR. The coagulation changes that occur in pregnancy and persist into the puerperium antagonize warfarin and may justify higher loading doses. The INR should be checked on day 2 of warfarin treatment and subsequent warfarin doses titrated to maintain the INR between 2.0 and 3.0. Heparin treatment should be continued until the INR is greater than 2.0 for at least 24 hours. Neither heparin, unfractionated or low molecular weight heparin, nor warfarin is contraindicated in breastfeeding. Since neither unfractionated heparin nor low molecular weight heparin is orally active, no clinical effect would be anticipated in the infant. Warfarin does not pass into breast milk to any measurable degree. It is 99% bound to serum proteins, which results in minimal transfer to breast milk. Prevention of post-thrombotic syndrome. What measures can be employed to prevent the development of post-thrombotic syndrome? Women should be advised that prolonged use of low molecular weight heparin, more than 12 weeks, is associated with a significantly lower chance of developing post-thrombotic syndrome. Following a deep vein thrombosis, a graduated elastic compression stockings should be worn on the affected leg to reduce pain and swelling. Clinicians should be aware that the role of compression stockings in the prevention of post-thrombotic syndrome is unclear. The post-thrombotic syndrome, or PTS, is characterized by chronic persistent leg swelling, pain or feeling of heaviness, dependent cyanosis, telangiectasis, chronic pigmentation, eczema, associated varicose veins, and in the most severe cases, venous ulceration. Smoking and age greater than 33 years were independent predictors of the development of post-thrombotic syndrome. Other recognized risk factors include recurrent ipsilateral DVT and obesity. A randomized controlled trial of long-term use of low molecular weight heparin, tinzaparin for more than 12 weeks versus tinzaparin for 5 days, then warfarin for 12 weeks in patients with proximal DVT reported a significantly lower rate of PTS in patients allocated to prolonged low molecular weight heparin. A sub-analysis has shown that the benefits of prolonged low molecular weight heparin are even greater for iliac vein DVT. Postnatal clinic review. Postnatal review for patients who develop venous thromboembolism during pregnancy or the puerperium should, whenever possible, be at an obstetric medicine clinic or a joint obstetric hematology clinic. Thrombophilia testing should be performed once anticoagulant therapy has been discontinued, only if it is considered that the results would influence the woman's future management. At the postnatal review, an assessment should be made of post-thrombotic venous damage, and advice should be given on the need for thromboprophylaxis in any future pregnancy and at other times of increased risk. Thrombophilia testing should be performed once anticoagulant therapy has been discontinued and only if it is considered that the results would influence the woman's future management. Testing will not alter the duration and intensity of acute treatment but may alter prophylaxis in subsequent pregnancy. Appendix number 1. Algorithm for the investigation and initial management of suspected pulmonary embolism in pregnancy and the puerperium.